Thank you and good morning everybody. I too, like Bob, would like to acknowledge the traditional owners of the land on which we're meeting and to pay my respects to elders past and present and the elders of any other community. And as Bob said, he's an elder of our community. Welcome, Bob. And I'm here today to talk to you a little bit about what's happened since the first summit. And I am sometimes a little bit challenged with these, but... So the first summit was back in 2014, late 2014. You can see from everybody's got their winter coats on. And it was held at the RACS up in Parkville, or sort of north of the city, sorry. And it was a smaller group, and it was our very first foray into this sort of summit. And I think it was an interesting experiment, and since then we have learnt an awful lot and a number of other aspects have changed. However, there was obviously considerable discussion in the room and people were bringing to the table their own local learnings and looking at what data we actually happen to have and trying to come up with some ideas about how we might work together to improve the system. There were a number of recommendations, and Mirella tells me they were modest recommendations. However, some of them are actually pretty significant. Revolutionising, if you like, say the colonoscopy guidance is pretty revolutionary rather than modest. But we have made some traction against all of the recommendations that were made, and I think it's helpful to group them into the three sort of subheadings of MDM, or multidisciplinary team meeting, efficiency and discussions, and being prospective and making sure that patients are discussed. There's a number of recommendations about monitoring data where that represents some good practice in the system. And the last one was around screening and promoting appropriate colonoscopy. So since then, there has been a lot of work where the recommendations or the original discussions at that summit have informed further pieces of work, which have been taken forward sort of almost independently, but in concert with the sort of work that came out of the first summit. So we have one of the key pieces of gaps, I guess, in the data that we had at the last summit was for rectal cancer patients, did they actually get discussed in an MDM, and was that prospective? So that was one of the key recommendations about undertaking a statewide audit, and that was actually taken forward, I think, in 2015. Kathy, is that right? So, of course, you have to sort of go forward a bit of time to look back so that you could actually then capture that data. There was further work that was undertaken to develop our analytic capacity, and I'll speak to that a little bit further in a minute, because we have actually been able to develop a rich linked data set, and we have, as a separate piece of work, done some development of a performance monitoring framework, which sort of goes alongside having the data capability. We've also implemented the Optimal Care Pathway for colorectal cancer across Victoria. We've highlighted, there has been the sort of messages that have been taken back to the department in the prevention and screening area around colonoscopy have obviously been heard, and we wouldn't have been the lone voice, but there has been a significant amount of work on developing some guidance around categorisation of patients for colonoscopy. And there is an update on your desk, and you can read that at your leisure. Oh, did I miss something? So going back to the issue of the linked dataset, this is new from the last summit. We have had a change to the Cancer Act, and we now have the Improving Cancer Outcomes Act, which makes it very clear that the Victorian Cancer Registry belongs to the Secretary of the Department. We have, through the data linkage unit, improved the algorithms for matching so that we actually have a very robust data set now that links the inpatient activity, it links the cancer registration details, which includes a lot of detail about the tumours themselves, and it also links the radiotherapy data set, which is public and private. what we don't have, also the data from the death index, and that comes in through two sources, both the Victorian inpatient dataset as well as through the VCR. The Cancer Registry is also has the advantage of being linked to the National Death Index. So if somebody dies interstate, we still capture that information. There are, of course, some limitations. It doesn't capture out-of-hospital care, except for, say, radiotherapy, which is considered ambulatory, and the radiotherapy dataset captures both public and private. But I think, Brian, you're going to touch on this anyway. There are some assumptions when we look at the data where we try to take, say, information about coding of metastatic disease and interpret that as, you know, the patient actually having metastatic disease. Interstate treatment is not included, so this does impact HUME. However, it doesn't impact the radiotherapy or the cancer registrations for those patients. So it's incomplete, particularly, as I said, around Albury-Wodonga, but it is still a very robust data set. The other thing that was mentioned was monitoring, looking at the data. One of the things was looking at the number of nodes collected on, when a resection was done, and that has been captured into the process which developed and tested 9 quality performance indicators, and that was a very extensive and inclusive process which looked at a whole range of indicators, and then through a process of iteration with the sector, with clinicians, refined that down to 9 to test. 3 separate years of data in a report was circulated for the information and feedback of the sector, and this performance monitoring framework will now become more routine. As I'll mention it here, we are also looking at developing this as an automated online portal which would put more significant data analytics in the hands of local clinicians. Bob's already mentioned the optimal care pathways, but in 16-17, the department decided to support the implementation of colorectal and lung cancer OCPs across the state. This was in the context of the Council of Australian Government supporting implementation within existing resources at the state level. The aim was locally to identify and address opportunities for improvement. We took a multifaceted approach, and I'll go through some of the results of that approach, and it was very much based on partnerships, building partnerships so that it represented the pathway, and it was going to be data informed. So the partnerships have encompassed the integrated cancer services, the adult ones, the Primary Healthcare Alliance and individual primary health networks, the Cancer Council Victoria and the University of Melbourne, who undertook a particular piece of work called iPaste, and I'll talk to that in a moment, but it involved academic detailing in primary care, which becomes an important area of focus if you're looking at referrals of patients for colonoscopy or for further cancer workup and treatment. So the Tumour Summit's analyses and recommendations significantly informed the work that was done locally to identify gaps in the system. Particularly too, I think the rectal audit also informed what might be of interest or an area for particular improvement focus at a local integrated cancer service level. And we've had some impacts locally because I think it's not perhaps as, it was all a bit of a new thing. There were lots of learnings, and we're all sort of experimenting and trying to work out what was the best way to approach this. And obviously, because we took the view that locally was where you should actually focus your effort, it meant that we weren't all working on exactly the same sorts of areas for improvement. And we've taken that learning through to this next tranche of implementation, and we'll have a much more consistent approach. And we're hoping that that will help us achieve impact at scale. So again, this is in your data pack, but this is the results of the audit for patients who had rectal cancer, and in 2015 we looked at whether or not they were discussed in an MDM, and you can see that there is considerable variation against the target of 95%, which was set by the group. And following the implementation work, we have had some areas, so obviously 2 weeks picked this up as an area for improvement. And, sorry, I have to take my glasses off. Gippsland worked on this and improved their rate through the implementation process so that 84% of patients were discussed at an MDM. And, I'm missing a dot point. There was also another result where Grampians also sought to improve their outcomes, and so they increased theirs up to 74%. So obviously with some local focused effort, then you can actually see some improvements. The audit also showed those patients, it's in blue, that were discussed prospectively at their MDM, and one of the ICs actually focused on this. And so, again, Grampians increased there so that 55% post the implementation were discussed prospectively. Other particular areas also had a focus and achieved improvements. Now, I do have to confess, down the bottom, the Barwon Health, their improvement in those patients who were screened for supportive care was actually up from 17%, so I've undersold them in the pre, but they achieved 60%. Some of them, if you look at NEMICS in Eastern Health, they had significant impact on the time for people to get access, which is, just goes to show that with a bit of focused effort, you can actually get these improvements. Loddon Mallee, they also had a focus on the referrals that they received from primary care around colonoscopy. They identified that the quality of the referrals were inadequate for them to adequately triage patients. And so they did some focused work in this area. And you can see, although, it's a bit of a slow gain, they certainly made a significant impact on the attachment of the FOBT results where that was positive, because that would actually help inform that triaging. I talked about the relationship with the primary health networks earlier. So in primary care, they have a program called Health Pathways, which they embed in general practice software, which provides information to GPs at their fingertips so that they can make the appropriate referrals, understand where patients need to go. And they, through this initiative, the OCP implementation had taken information from the Optimal Care Pathways and embedded that into the software. Now, this example is from lung, but they obviously also did that for colorectal, and they're doing it progressively across the Optimal Care Pathways. So that information means that the GP at their desk will have information that is consistent with the pathways. This is a slide showing the GP education process that was conducted by the CCV and University of Melbourne, where the academic detailing reached into a significant number of general practices to talk to clinicians, the nurses, the GPs themselves, to update them about what's required and how to identify and patients based on their risk, which is on this next slide. You can see there's a risk grid down the side, and GPs or primary care practices were educated in the use of that. The reach of this, including not just the iPace but also the other general practice pieces of work through the primary health networks, has meant that we've actually reached 68% of all general practices across the state, which is such a significant sort of reach, where they're all being informed, educated. There is a process where the OCP two-pager that is on your desk can be embedded into their software, and that process is also part of this initiative. And in terms of the iPace, some of their impacts. Now, I guess one would hope that the GPs would be able to recognise some of the symptoms, but you can see that even there's been an uplift even in that area. But there's certainly been an uplift in how and where people are referred, and so the patients can also have that discussion with their GP, and the GP feels very confident to be able to explain to them what the significance of the test might be and what the next steps are likely to be. So we see that as a bit of a win. And lastly, the guidelines. Now, this has been a fairly long process, but a very important one to try and develop some agreed categorisation guidelines to inform colonoscopy waiting lists. And this is important because there have been pockets where there have been difficult access for public patients, and also where we think that many patients, or there are a number of patients, who are perhaps inappropriately being screened using colonoscopy rather than other means. So the DHHS, the screening and prevention area, and I don't know whether there's anybody here from that part of the department, but they took the lead on this and worked with the college and the University of Melbourne to pull together an expert working group to develop these categorisation guidelines. They undertook a survey of the sector. They also did a literature review and developed the guidelines, which were then tested in a number of, I think it was 4 sites across the state to check that they were helpful. They also undertook a validation against 3,000 medical record reviewed cases to check whether or not the tools were appropriate in the outcome of what the category that they allocated patients to. This was a really successful process, and it did show that these new guidelines are more sensitive and specific than other ones that are currently in place. There is a little bit of a word of caution though, because of the 3,000 cases that they validated against, a number of those referrals didn't have sufficient information for it to be done appropriately or accurately. And I guess that goes to some of the work that Lot and Mally did about trying to get that right, and also the work through the primary health networks, how important it is that those GPs and the primary care practices are educated to make sure that they provide the relevant information so that health services can categorise appropriately. So these will be rolled out, implementation by 1st of July 2018. Now that's not very far off, so obviously the sector is being very busy at the moment implementing those. And the next step is to look at gastroscopy as the other part of the activity in the relevant suites. And there are a number of people who should be thanked, you in particular. You are the sort of, I guess, the early adopters, the ones who are perhaps going to be the champions for the sort of work that comes out of here. I've presented the high-level stuff, but many of you will have been involved in work at your local level, and you can take forward things at your local level. You absolutely have control over whether or not patients are discussed at MDMs, what that discussion is like. There is another piece of work that is coming through that is looking at the quality of MDMs and sort of a review and accreditation type process, if you like. And a number of you will be involved in perhaps pilots around that. And I'd encourage you to take those opportunities, because that's how you can actually have your own local influence in what you want to do and achieve for your patients. Because obviously we're all in this together, and we need to, act locally but think globally, because it is the systems that are important as well to make sure that patients get the best outcomes.